Thank you for joining us today for the In the Know podcast series. My name is Nirmala Pereira and I'm your host today. I am the social media coordinator for the IOC World Conference on Prevention of Injury and Illness in Sport. I'm also a member of the Sport with Us injury program at Linköping University, Sweden. Currently, I work as the Clinical Research Project Officer at the AIS. Today, our guest is AIS CMO Dr. David Hughes. Welcome to the podcast, David.
Thank you, Nim. It's really my great pleasure to be here. Thank you for having me on.
It's my pleasure, David. In a nutshell, can you please tell us what you have been up to in the last few years?
Sure, I can. Well, look, I actually my first forte into sports medicine was in 1990 and 91. Shows you how old I am. But well, I did the postgraduate diploma course in sports medicine in London, and some of those people I met during that year are still close colleagues of mine all these years later. But I then came back to Australia and did sports medicine training and became a sport and exercise medicine physician in 1995. Went into private practice and worked with a range of professional sports. I had the great fortune of being able to go back to London in 2003 and 2004 to assist with setting up a sports medicine practice there, and had the opportunity to work with English Premier League and Premiership rugby teams in London, and again made lots more friends over there who I still stay in contact with, and then came back to Australia and continued on in my private practice, but switched across to the Australian Institute of Sport in 2013, and since I've been here, just with the nature of the AIS, my focus has switched a lot more from professional sport to Olympic and Paralympic and Commonwealth Games sports, and I've been here ever since, and really enjoying my role here at the AIS.
Wow, that's an amazing CV, David, with a wealth of experience in sports medicine. I also noticed that you were the medical director for Rio Olympics and for the Tokyo Olympics. I noticed that you worked in high-performance sports as well as professional sports. In your experience, can you please explain to me what's the difference between the two?
It's a good question. I think the fundamentals are the same, which are there are very driven people who are working really hard to improve themselves on the sporting field. Obviously, the difference is that in the majority of Olympic and Paralympic and Commonwealth Games sports, there is not the financial reward that there is in professional sports. I suppose the main difference is that probably there are less resources in a lot of the Olympic and Paralympic and Commonwealth Games sports, and but the fundamentals around what we need to do to prepare athletes and for athletes to perform optimally are the same. And but I really enjoyed the variety of of sports that we're in contact with in across, in this role with Olympic, Paralympic and Commonwealth Games, as opposed to professional sport, where you tend to be very one sport focused and often one team focused. So your patient cohort, is often 25 people, and you see them day in, day out all year, that's got its positives and its negatives, and so I suppose there's probably a bit more variety in this role.
You also advise Australian government on matters of COVID-19 and sport as a member of the Sport Health Advisory Committee. Can you please tell us a little bit more about that role?
Yeah, so look, obviously the whole world has been through a very traumatic time with what's gone on with COVID-19. Here in Australia and in many places around the world, things are improving, and we've been very fortunate in Australia. And I really count our good luck that we have very low transmission rates at the moment. Doesn't mean things couldn't go bad in the future, but things are going well, and we are looking at starting to reopen sport. And so as soon as our numbers started to flatten off here in Australia, yes, we started to look at the fact that if the government was going to, at some stage in the near future, allow society to start to move back to some form of normality, we felt that we had to ensure that there was some sort of a plan in place for all of sport, whether that's low-level community individual sports or high-level professional team sports, some sort of a consistent framework that teams had a plan or a roadmap to work their way out of this through this uncertain time. And the Sport and Health Advisory Committee is a very recent development where the government has set up a committee to advise the public health officials and infectious diseases officials that are advising government to bring some sport and exercise medicine expertise into a group so that we can provide our knowledge of the sporting environment when government's making decisions about opening up the community such that sporting activity can resume.
Thank you for that, David. How about we first talk about COVID-19 and the AIS framework in general first. Then perhaps we can look at the aspects of framework relating to high performance and professional sports, community sports, and then individual sports. So, can you please tell us a little bit more about COVID-19 and sport?
COVID-19 was something that clearly didn't exist a year ago. It's a type of coronavirus. The virus is known as SARS-CoV-2. And this virus causes the disease state known as COVID-19. It probably started in China somewhere around November or December last year. China first officially reported the disease to the World Health Organization in late December. And it is a highly infectious disease. We know that somewhere back in November or December, one person had this disease. Now, as we're speaking in mid-May, we know that around the world there have been over 4 million cases officially diagnosed, but probably many more that have not been diagnosed. And there have been in the vicinity of over 280,000 deaths, which is a tragedy and really causing great difficulty for many countries and has overwhelmed the health systems of several countries, which has been devastating for those health workers working in those terrible situations and devastating for communities. This pandemic has disrupted our modern way of life around the world in a way that nothing else ever has before. As we speak, international borders are closed. Around the world, people are not attending work. You and I are speaking via video conference instead of face-to-face because that's the way we do things at the moment. Clearly it has completely brought sport around the world to a standstill. And when we first closed down maybe 6 or 7 weeks ago here in Australia, Australia was on the same curve in terms of transmission rates and new cases as Europe and North America, and it really appeared that we were in for a very long haul. We really, from late February until late March, we had a very steep increase in cases, and we were doubling our cases every 3 or 4 days. So the outlook was very bleak, but then with a range of government measures, including closing our international borders, restricting travel between regions of Australia, practicing social distancing, closing down workplaces, closing down community centres such as cafes and restaurants and bars. Those things started to have an effect late March, and we saw the average annual daily increase dropped from over 30% on around the 24th of March to being less than 1% over the past several weeks. And in fact, really probably for the last fortnight, the average number of total new cases around Australia has been in the vicinity of 20. Sometimes it drops down as low as under 10. So we've still got a few cases bubbling along, but we're in a much better position than we thought we would be when we first started closing down 6 or 7 weeks ago.
I completely agree with you. Australia's done a great job flattening the curve. But I'm wondering, why did you decide to create the AIS framework?
I think it was because I didn't anticipate doing this for some time, I suppose. When we literally closed the AIS and went to home and started working from home, the outlook was that this would be something that was in place for many, many months. But as I've outlined, once the numbers started to even flatten, it just occurred to me, what's going to happen if we do a lot better than what we were expecting in terms of the community transmission rates? What if the government turns around to Australian society and says we can start to ease some of these restrictions, will Australian sport be in a position where they're ready to move, and they have a clear idea in each sport and at each level of sport what it is they are permitted or not permitted to do. So it became clear to me as the numbers started to drop that we really needed to move quite fast and put in place a comprehensive framework, not to tell sports what to do, not to give anybody instructions, but to as an advisory resource where we made some recommendations about what we thought was an appropriate level of activity at different stages of the resumption, and also just to give, I suppose, to give sports a pathway where they could look forward and see some steps onto a resumption of activity. And we're also very keen to ensure that whatever framework the AIS put in place was had some basic tenets that whatever we do should not endanger the health of the community or the health of athletes, and that any resumption of sport should happen in a very careful, stepwise, methodical but cautious manner, because one thing we know about this virus is it is highly contagious. We know that if you drop someone into a society where there is no social distancing and they have COVID-19 and they are not diagnosed, that you can expect over the period of a month that they would cause another 400 infections. So all it would take in any section of society, whether it's sport or some other sector, would be to have a couple of undiagnosed cases moving around to suddenly cause an outbreak or a spike in cases. And we have seen in Australia, we had an issue down in northwest Tasmania recently where they went from having very few cases to suddenly having over 100 cases in this particular region, and that required the closure of 2 public hospitals, the emptying of those hospitals, deep cleaning of the hospitals, the isolation of 4,000 or 5,000 people, including many healthcare workers, and then we had to have healthcare workers come in from the mainland to then take over duties of providing healthcare in that region of Tasmania. So that was a very major effort, but very effective. But I think when you see how I suppose the significant measures that government is required to take when there is an outbreak, we need to look at that in sport and understand clearly that if we are the source of an outbreak, the organisation involved will be likely shut down, and it could have ramifications not just for that organisation, but more broadly in sport, if there is a perception that sport is a vehicle for creating transmission of this virus.
You involved a wide range of stakeholders in the development of framework, from sport to experts in infectious diseases, public health. Can you talk a little bit about how the framework was developed and the principles guiding the framework?
Yeah, well, clearly COVID-19 is primarily an infectious diseases and public health issue. I mean, specialists in those areas are the experts who really drive the government response in Australia and overseas to this new virus. And fortunately, the Australian government listened closely to the advice provided by senior public health and infectious diseases specialists. And I think those specialties can really take the credit for Australia doing better than what we were thinking we might. And it was clear to me when we started putting together a team to work on this project that this couldn't just be a document coming from sport and exercise medicine. While clearly we are the experts around what is involved in sport and we have expertise in the sports sector, it was clear to me right from the start that we needed to work closely with infectious diseases and public health specialists. And I was very fortunate to receive very good support from the Commonwealth Chief Medical Officer and Deputy Chief Medical Officers as we put this project together. We had a team of about 6 or 7 people working here at the AIS, working very long hours across weekends and across Easter. And we wouldn't have got it done without that team being so willing to roll up their sleeves. But as you say, when it went out to, we described some high-level descriptors where we described different levels of activity as level A, level B, and level C. And I might describe those first just for your listeners.
Yes,
that level A was the level of activity we were at during lockdown, which was that individuals could go outside to train as individuals or with one other person, as long as they maintained a social distance of at least 1.5 metres, preferably more than 2 metres, between exercising individuals, depending on what sort of exercise they were doing. They were not permitted to share equipment. They wouldn't have clearly no sharing of towels or any other implements, and they were not allowed to be in any contact with each other. So that was level A. Level B is where we allow groups to come back together in groups of up to 10, and that includes athletes and any coaching staff. And the idea behind this is that as we get to level B, we want to ensure that anybody undertaking sporting activity, when they're in this group, has a maximum of 9 other contacts, because each person brings their own infection risk with them. They don't know what their infection risk is, and neither does anybody else. But if you're coming back into a group of 10, you've got a maximum of 9 contacts. If you bring back 50 together, you've got a potential, contact group of 49. So that's the rationale behind having limited small groups. At level B, there was no deliberate contact. Incidental bumps were tolerated. There was some limited sharing of equipment permitted, which, say, sharing of basketballs, footballs, tennis balls, skipping ropes, gymnasium equipment, on the clear understanding that in between sharing of equipment and in between groups of 10 coming in, the equipment was thoroughly cleaned. So that was level B. I think that covers most, but we also allowed that at level B, we recommended that be allowed outdoors or indoors. And then as we went to level C is back to sort of full contact training for those sports that involve contact, full competition and match play. But to be really clear, we're not going back to the situation that we were in prior to COVID-19. So even when we go back to level C, if we get there, we're certainly not there yet. But if we go back to level C, those measures that we've all come to know so clearly over the past couple of months, such as enhanced hygiene, washing hands, entering and leaving the training environment, maintaining social distance where not possible. So if you need to come together and be close together for, say, basketball drills or rugby drills, that's absolutely fine when you need to do it for the sport. But at all other times where you can maintain social distance, you should. And clearly a lot of cleaning of shared equipment, potential contact surfaces, etc. So levels A, B, and C. And if I could just go back to B, one of the key principles overlying level B is the idea of get in, train, and get out. Okay, so I see level B as being where we're at quite considerable risk, because it's the first time, if you like, that sport is sticking its toe in the water, coming back together and seeing how we go at level B. And normally in sport, people would come together, sit in a change room, have a bit of banter, have exchange jokes, show each other, photos or funny memes on their telephones, etc. Unfortunately, that is no longer permitted in this new environment. So when we move from level A to level B, athletes should prepare as well as they can at home. Get dressed, get into their tracksuits, strap their ankles if they can do that themselves. Go to the training facility, whether that's a swimming pool, a basketball court, a soccer field, a rugby pitch, whatever it is. Go there, take your tracksuit off, get in, do your training, put your tracksuit back on, go home and do your stretching and your showering and all that sort of thing at home. So no hanging around in change rooms, communal areas, showers, etc. But obviously what level A, B, and C actually reflects in specific activities looks very different between water polo and rugby. Looks very different between football and swimming, or badminton, or motorsports. There's a whole range of sports, and that's where we drew on the expertise of the chief medical officers of our various national sporting organisations. We drew up the high-level descriptors. We then asked them to to look at the high-level descriptors and knowing their expertise from their own sports to write under those descriptors in collaboration with their own performance directors and others involved in their sport what they think are the appropriate terminologies to make it so that anybody, say, doing rugby around Australia can look at the rugby descriptors and clearly understand what activities are permitted or not permitted at level A, B, and C.
That's pretty impressive. There's something for everybody. And I see that your sport-specific tables cover from community level sports to high performance and professional sports. So there's something for everybody, but there's quite a lot of work involved as well. Were there any challenges pulling this together?
Yeah, so look, I think that's where it was really great to have that expertise coming in from the sports themselves. And we're still sort of in negotiation. There's still sports coming back to us saying, could we tweak our wording a little bit because we just worked out that this probably doesn't quite work, or we've had some feedback. So we have it as a live document on the AIS website. And for your listeners and viewers, I think I should make it clear that the attitude of the AIS is that this is not something that's just for the AIS or just for Australia. This is a health issue. It's not a performance advantage issue, and these documents are live and freely available to anybody for whom they're useful. There may be some countries around the world who don't have resources, or sporting groups anywhere in the world who may use this as a tool just to stimulate their thinking. As I say, it's not telling anybody what to do. This is the recommendations we've made to our own sports, but I'm hoping they could be useful for others. So if your listeners or viewers go to www.ais.gov.au, and it'll be the first thing on the website, the AIS Framework for Rebooting Sport in a COVID-19 environment. And I would welcome anybody to go to the website, download the documents, adapt them as you will to your own environment, and if that assists others in creating a safe environment for resuming sport in whatever country or region they come from, then we'd be delighted with that.
Okay, great. I have a question. So who can make a decision for moving from level A to level B or from level B to level C sports activities?
When we talk about the right time to go from level A to level B, to be very clear, that's not a decision for sport. That's a decision for public health officials based on a range of parameters that they look at. One of the parameters I'll look at is the reproductive number, or R number, and some people refer to the R, the effective R number, which is the rate at which the virus is transmitted in the community. And if the R number is greater than 1, that means that each case of infection is causing multiple other cases, so your numbers of cases are growing. If the R number equals 1, it effectively means that the same number of people are recovering from COVID-19 as are being diagnosed with COVID-19, so your active cases are remaining stable. And if the R number is less than 1, then you've got more people recovering from COVID-19 than being diagnosed with it, so therefore your numbers are decreasing. And I think before you'd move from level A to level B, you would want to see that the R number has been less than 1 for a period of time. Now, it's debatable what that period of time is. We sort of felt that somewhere around 2 incubation cycles, and each incubation cycle being about 2 weeks for this particular virus. So 2 incubation cycles would be 4 weeks, and we feel that if the R number had been less than 1 for a couple of incubation cycles, then you could probably move from level A to level B. My strong urging to sports would be that they don't feel in a rush. We've only got one bite at this cherry. What we can't afford to have anywhere in the world and in any society, certainly what I don't want in Australia, is for sport to be the cause of an outbreak or to be the source of an increase of transmission of this virus. So let's go slowly, because if we do it right the first time, everybody will benefit. We all want to get back to sport. People are going crazy around Australia, as they are, I'm sure, in many other nations around the world. They want to move back towards normalcy, and sport culturally is very important as part of that, getting back to a normal society. So I think once you get to level B, remember that whatever change you make in society, whether it's closing things down or opening things up, you won't really have a clear understanding of what the effect has been on community transmission rates for a couple of weeks. So we have to see what happens. And so my advice again would be that ideally you'd wait for a couple of incubation cycles at level B. Make sure that we're not getting outbreaks occurring related to sporting activity. And if all is going well, then you could move to level C. But there are other things that public health officials take into account, such as the ability of the healthcare system to cope with outbreaks, and that can vary in different regions of different countries. So it may not be uniform across the country. And certainly here in Australia, we are seeing some states moving before other states and territories simply because may have had extremely low rates. Places like the Northern Territory in Australia have had almost no new cases for close to a month, I think, certainly for several weeks, and so they are probably moving a bit faster than some of the other states. So some states being more cautious, and that's absolutely fine because it's the public health officials on the ground in those states or territories that have the best understanding of what the local transmission environment is and have a feel for how things should proceed. But so there are several things that get taken into account, but my advice would be, even if the government says you can go to level C, sports have to make their own decision too. Do they have the resources to move from level B to level C? Do they feel confident that they've got a plan in place, that they've been able to educate the athletes and the officials around this disease? And I think perhaps one thing that I should touch on is that one of the key things underpinning the framework is the education piece. Like that starts at before the athletes come back in. The athletes and the officials should be educated, and certainly here at the AIS, as we're looking towards bringing athletes back onto the campus here at the AIS in Canberra, one of the key pieces is some teleconference education sessions where we really explain clearly what COVID-19 is, how it's transmitted, what are the things we can do in their specific sport environment to minimise transmission, what are the procedures going to be for monitoring, for firstly clearing athletes as being well. And there we're looking at collecting some data via their telephone, where they can enter data about their own health over the past previous 2 weeks, because we expect athletes to have been well for a fortnight and then to have an examination and be cleared as fit to play. This is in high performance sport. Not always, these facilities aren't always available at community sport, but effectively I think at any level of sport, we would recommend that an individual has been well and been feeling well and have no symptoms and examine well before they re-enter the training environment. But the education comes first, then the screening of the athlete, and then we have to monitor the athlete, and that can take the form of, depending on resources and other things, daily temperature checks as they come into the training environment. They can take their own resting pulse rate first thing in the morning to check that their resting pulse rate is not elevated, and also a very low threshold for testing. So really the point we're at here in Australia, we're very fortunate. As I say, at the moment we're averaging somewhere around 20 cases per day around Australia. Still hoping to push that down lower, but we are doing very expansive testing. So we've got one of the highest testing rates in the world, very aggressive procedures for following up contacts of infected cases. And the advice from public health officials and our advice to sport is that we have a very low threshold for testing. Anybody with any respiratory symptoms, and really anyone who's unwell, the criteria is expanding now to include gastrointestinal symptoms. And we say to people, if you're at all unwell, do not come to the training environment. Do not come to the sports medicine centre. Ring ahead and let us know that you're unwell. We have set up procedures here at AIS Medicine where we'll be running if you like, a COVID clinic each day for anybody who has potential symptoms that could suggest they need testing. We'll have very clear procedures around that in terms of use of PPE, taking the swabs and things that are required for PCR testing. So very low threshold, and that's one of the I suppose knock-on effects for that for sport and for coaches and managers and other support staff is they need to realise we are not going back to just how sport was before. because of our low threshold for testing, anybody with a respiratory symptom will be tested for COVID-19. That means from the time we decide that they need testing, they are effectively suspect. That means they go into isolation, they can't rejoin the team, and it will take 24 or 48 hours to get that result back. And at that point, in most cases, we expect it to be negative, but with mild symptoms and a negative test, we would let them go back to training. If it's clearly, if they had a positive test, then that goes down a whole nother pathway. But we've clearly articulated that in the framework, what our process is for clearing athletes and monitoring athletes and then testing athletes to ensure, and when I be clear here, not just athletes, but athletes and officials, because officials are also could potentially bring the virus into the training environment. So really all I would say to any sports or any of your listeners who are working with sport and who haven't thought about this at this stage, I know a lot of people have been thinking about it, but I think that the AIS framework can potentially provide you just with a framework clearly to think about the sort of processes that you might need to put in place around your sport to keep your athletes safe and to ensure that sport does not become the source of an outbreak of COVID-19 in the community because we didn't take enough care.
That's great, thanks. So it is very likely that sport might not get back to the way it was pre-COVID-19 for quite some time. And we talked about the get in, train, get out principle. Some athletes may have not been training for the past 6 weeks or even longer. And what could be some of the implications for these athletes returning to sport?
So I think there's been a lot of work that's been done by many great researchers around the world into the issues of load management. And you can imagine that athletes and coaches and everybody who's been in lockdown around the world, as they have the opportunity to get back into the training environment, there can be the temptation to go at it like a bull at a gate, so to speak. And again, we would urge caution because certainly there's plenty of evidence out there to suggest that people coming off a low training base who increase their training too quickly are at increased risk of musculoskeletal injury, and that would be extremely frustrating for an athlete to come back after a long period of layoff, to get back into the pool, on the court, onto the field, and then to sustain an injury because they just went a bit too hard too soon. So I would urge coaches and trainers and other support staff to be very mindful of the fact that individuals are undertrained, and they will need to have a plan for gradually increasing the training load if they want to avoid or minimise the risk of musculoskeletal injury. Another point that I think needs to be considered is the issue of the athlete who has had COVID-19, sometimes there is a test. There are antibody tests being developed around the world, but my understanding of the evidence for those tests right now in mid-May 2020 is that the tests have not been fully validated. I know here in Australia there is a lot of research going into those antibody tests, but our high-level public health officials tell me that when they look at antibody tests, they really do not feel confident to make management decisions based on those. I think there are still unacceptably high levels of false positives and false negatives. This is a new virus, and we're learning. Hopefully, reliable antibody tests will be available soon. But until that time, we're really reliant on history to try and ascertain whether we think someone may have had COVID-19 in the past. And certainly, if someone has been diagnosed with COVID-19, or there is a strong suspicion they've had COVID-19 in the past, then we need to consider what could that mean for the health of the athlete, particularly an athlete returning into really high intensity exercise. One of the things that we've learned about COVID-19 over the past couple of months as more research has come out of heavily affected areas in China in Europe and in the USA is that COVID-19 is not just a respiratory disease. It's a systemic disease that causes multi-organ pathologies, including cardiac injury, hepatic dysfunction, renal injury, neurological dysfunction. So we have to be very careful, and my public health colleagues are very adamant with me that, you know, if they had someone who had COVID-19 who was going to go back into very high intensity activities such as, say, endurance cycling or rowing, competitive rowing, where you're working at a very high threshold for prolonged periods of time, then we need to absolutely make certain that their cardiac function, respiratory function, renal function, etc., is all okay, and that they are not at risk. We're still learning about this, and we don't really have much experience at this point in time as to put, regarding the ability to put those who have suffered from COVID-19 back into really high intensity exercise environments. And it's something that we're going to have to tread carefully with, and err on the side of caution would be my advice to my colleagues around the world. We don't know, and we may know a lot more in 12 months from now, but, you know, right now I think we're obliged to err on the side of caution when returning those who have suffered from COVID-19 back into high intensity exercise environments.
Another point I would like to discuss is that within the framework, you not only looked at the physical aspect, but you also looked at the psychological aspects. Can we talk a little bit about the mental health of athletes?
I think there's many facets about this disease that impact on mental health. Firstly, we've had the shutdown. So people who are used to high levels of exercise as part of their daily life, it's part of their identity of who they are, that they train, you know, big hours every day, day in, day out. They've got a goal that they're following in terms of what they're trying to achieve in their sport, and to have them suddenly locked up where they don't see their teammates, they don't see their coach, they don't they can exercise in ones or twos, and depending on what their home circumstances are, they may have had very little ability to exercise. Clearly that will have an impact on their mental well-being. And then for those who have had COVID-19, or those who fear getting COVID-19, having been locked down for 6 weeks, 8 weeks, 12 weeks, then starting to come back into the training environment and trainers groups, when you've been in a mindset of avoiding all contact with others, how do you adjust to suddenly going back into this and feeling safe? Because you have to feel safe to be relaxed, to be mentally well, to be confident. You have to feel relaxed in the training environment. And I'm certainly getting anecdotal feedback from some of my colleagues here in Australia and overseas that there is a sense that some athletes are actually quite anxious about going back into the training environment because they've taken on board all the advice about social distancing, and now the thought of going back into that situation where you are training in groups, etc. For some of them, there's apprehension, and perhaps some of them actually are thinking that they're not that sure that they want to go back to training. So there's going to be lots of things that we're going to have to deal with that are going to be new to us, and it's going to be a learning process. And I hope that one of the great things about sport and exercise medicine is that it's a small community in Australia, and it's a small community globally. I have excellent relations with my colleagues in a range of countries overseas, and it's always worthwhile talking to each other and sharing experiences. But I think it's going to be really interesting from a medical science point of view to see how we deal with all these challenges over the next 12 months. And there's going to be a lot we know in 12 months that we don't know now.
Things like sharing drink bottles, celebrating after scoring a goal, all that needs to be changed within a COVID-19 environment. And athletes players need behavioural change from their part, which can be quite difficult for them.
Rules
exactly.
too.
There's going to be lots of things, and that's going to affect lots of procedures on sidelines. How do you take care of a rugby team and make sure that everybody has an individual bottle, and that in the heat of the game there's no sharing of bottles, etc. All that sort of thing. It's challenging.
You left no stone unturned and you looked at risk groups. Can you please tell us a little bit more about who's at risk from COVID-19?
Yeah. Look, vulnerable. I think when we're bringing people back together, we do definitely need to be careful of vulnerable groups. I suppose when I'm thinking of Olympics and Paralympics, I think about Paralympic athletes, many of whom may use wheelchairs or use prostheses and other equipment that effectively requires contact. Some of them have other comorbidities because of issues that were the cause of them having a disability, and some of those comorbidities can predispose individuals to infection. We have groups that we know just in society are at higher risk. So those who suffer from conditions like diabetes and hypertension are at higher risk. Those from lower socioeconomic groups tend to be at higher risk of a range of conditions, and there's no reason to think they wouldn't be more susceptible to these conditions as well. Depends on their living circumstances, how many people in the house, what is their ability to maintain social distance in their living environment, in their work environment. And there are some groups, say in Australia, we have Aboriginal and Torres Strait Islander communities who often are remote, have poor access to medical facilities. Their culture tends to be one of large groups living together. And again, that whole social distancing thing can be quite difficult, and we have to ensure that as we resume sporting activity, we do take into account any groups that could potentially be more vulnerable to this virus spreading within their community once if they were to be exposed.
Okay, so what can we do to make sure that these at-risk group are safe when they return to sport?
For these groups, I think, again, key is education, to make sure we educate the groups and make sure they understand the disease and why it's important to social distance, particularly when it's at odds with what their normal culture is, to be sharing, to have, to invite people into your home. So we need to explain clearly why we're doing this. We need to improve healthcare services. I know that here in Australia, the Australian government is pushing a lot of healthcare resources out to remote communities to ensure that there is access to testing facilities and educational resources, etc. So I think, it's really around education and access to good medical services that are the key points for assisting vulnerable groups. And where it comes to things like wheelchairs or making sure that there are cleaning processes in place around anything where there could be potential contact surfaces that perhaps others don't need to deal with.
That's a great summary about the overall AIS framework. Now let's shift focus a little bit and look at high performance and professional sports. Do you think they are exception to the rule, or are they the role models?
Yeah. Look, my personal view and our view in the framework is that this virus does not discriminate. It doesn't discriminate between people who are getting paid 1.5 million Australian dollars per year and those who are getting paid 15,000 Australian dollars per year. The virus can infect people easily as readily. It doesn't discriminate between recreational athletes and high performance athletes. The Australian government has said that the AIS framework must be the baseline minimum standard for high performance and professional sports to satisfy before they consider any resumption. If there was a situation where a professional or high performance sporting organisation felt that they warranted exemption, they would have to convince local, state and territory public health authorities that they have procedures in place which actually increase their level of safety and make their risk of infection actually lower than the rest of the community if they were asking to be allowed to go to a higher level of physical activity before the rest of the community. That would be a decision at the end of the day for those local, state and territory public health authorities to make, and they would have to be convinced that the clearly articulated plan put forward by a high performance or professional sporting group did actually lower their risk, and that may be that they're operating in a closed environment where they're not mixing with the public, and that they're kept away from crowds, and that there's very close medical monitoring of them, and more close medical monitoring than what can be achieved, say, at the community level. So, on the basic premise though is that the infection can infect, a high performance athlete just as readily as a community level athlete. So there is no inherent reason why high performance sport should move more quickly, but they may be permitted to move more quickly if they can satisfy authorities that they have extra layers of security in place which lower their risk relative to the rest of the community.
So high performance and professional sport have a lot more resources compared to community sport in terms of ongoing monitoring, managing suspected cases of COVID-19. What are your thoughts around that?
True, and as long as that is clearly articulated, and I think it brings up the issue of asymptomatic testing, because I note that overseas and here in Australia there have been some professional sports that are talking about doing asymptomatic testing of their athletes. It's an interesting issue to consider. Here in Australia, where we have very low community transmission rates, my colleagues in public health would say that if you have someone who has been well for 14 days and they're well when they come into the training environment, they examine normally, then the chance of a random test on them, just doing a test as a screening test, say a PCR test, the chance of you picking up positives is probably less than 1 in 100,000. And so then it begs the question, is this a good use of resources to be using tests on high performance athletes who are otherwise well? And one point that I'd like to make really clear is that all the testing, it doesn't matter how much money an organisation has or what capacity they have to do asymptomatic testing, all the testing in the world will be a complete waste of time unless there is the adoption of the personal behaviours, which are so important. It is the personal behaviours which are key to a successful return to sport. And those personal behaviours are minimising unnecessary interpersonal contact, making sure we wash hands as we enter and leave the training environment, do not touch your face, clean all shared equipment in between sessions, make sure that you don't gather socially more than is necessary, and have a very low threshold for not going to training and ringing ahead and contacting your medical support personnel and notifying them that you feel unwell, because there must be a very low threshold for testing. One of the great challenges here is that clinically, I as a doctor cannot examine an individual and tell the difference between a common cold and COVID-19. And so, as I mentioned earlier, that means we have to have a low threshold for testing. Those that are getting tested need to be isolated, so there is going to be much more disruption to the training environment than what coaches and support staff and athletes have been used to prior to COVID-19.
I'm glad you mentioned asymptomatic testing, because we know based on the data currently available that majority of people who contracted COVID-19 don't have symptoms.
The validity of asymptomatic testing probably varies from region to region and is really dependent on the transmission rates. If you have very high levels of active transmission going on in the community, if you have the medical resources to test broadly and to test asymptomatic individuals, you will have a higher pickup rate than, say, what we would in Australia right now, where we are right now with only 20 cases being diagnosed around the country, despite quite expansive testing where we're testing even the mildest of symptoms. So I think at the moment here in Australia, we are doing in excess of 30,000 tests a day, and we're picking up about 20 cases. There are a couple of programs in Australia where the government is deliberately doing asymptomatic testing of some groups like healthcare workers and others, but at the moment the pickup rate is very, very low, which doesn't mean that we don't have asymptomatic carriers out there in the community, but it probably means in Australia's case that we don't have a massive iceberg undiagnosed sitting there of a large pool of cases. Certainly there's absolutely no rule for complacency, and we it would take a very little tweak of bad luck to have a massive outbreak in a shopping centre or in a workplace or in a sporting environment. So we had no room for complacency. We have to step forward very carefully. We have to be very methodical in our return to sport, and we have to remember. And I've said this, and I might sound pessimistic, but I say to the CEOs and the performance directors and the chief medical officers of our national sporting organisations that as we return to sport, at all times we're only 2 minutes from disaster. It's only going to take a tweak of bad luck for us to have an outbreak that could, have big ramifications not only for that organisation, but for the sports sector generally, and of course for the community. We do not want to endanger the community. So we're certainly not complacent, and I feel. As we step forward, I certainly feel some apprehension about what the future holds, but I do feel that the AIS framework has given us at least some sort of a systematic approach which has been adopted broadly across the Australian sports system, from the grassroots to the high performance and professional settings. And I think just by having a widely adopted framework, there is at least a consistency of language, a consistency of approach. And as we go forward, if there are little outbreaks here and there, we can learn from each other and we can understand what things work and what things don't work. But again, I have to emphasise, whether you're a professional athlete or at the community level, it's those personal behaviours that will make the biggest difference to whether we are successful or not random testing or mass testing or spending millions of dollars on testing of asymptomatic individuals.
That's a great segue to shift our focus. So how does one apply a stage approach to community level sports?
Well, it applies pretty much the same way. The basic tenets are really identical about the numbers of people we bring together. I think at the community level, it's challenging and it's going to be frustrating because people are so looking forward to getting back to sport. And so when you think about a community or a football club, that might have 150 teenagers belonging to this community club, how do you work in groups of 10? And particularly if the community club does not have a great deal of resources for, they don't have a lot of staff for organising things. They rely on the volunteers and the goodwill of the parents. But sports need to be thinking about, getting approval from public health authorities to perhaps have, a group of 10 at each corner of the field that have nothing to do with each other, remembering that the underlying premise is that each individual resuming sport at level B must have, when they go to a training session, must have a maximum of only 9 potential contacts. And so it's really important, if you're going to divide into groups, that those groups don't mix, they don't arrive together and mingle, they stay well apart. They may even arrive at different times. You may schedule them at different times and have them training, but it'll be a great, they'll be, thrilled to be able to just, kick a football around and see some of their friends and enjoy being back on the field. But different states and territories are going to take different approaches. Some may say, nope, there's only 10 on a field, full stop. Others may say, as long as you can keep those groups widely dispersed and having no contact with each other, so that each individual only has a contact with a maximum of 9 other people, then you could potentially have 4 groups of 10 at different corners of the field, and then maybe have staggered shifts to try and have as many people go through as possible. But unfortunately, this is an inconvenient virus, and there's nothing I can do or anybody else can do to take away that inconvenience. And there'll be frustration, but I'll just say, at level B, be patient. Don't be in a mad rush to get to our final destination. We have to see how we go at level B, make sure that there's no outbreaks or increase in community transmissions, and then at an appropriate time, the public health authorities will indicate that we can move to level C.
So for community sport, volunteers are such a big part of the sport. And as we previously talked about, some of these volunteers might be in that high risk category. So how do you think the community sport will be affected, as well as those volunteers that might be at high risk?
We have to maintain social distancing. So when we talk about groups of 10 coming together, that's the athletes and any coaching staff. So you may have 9 athletes and a coach. Now, often, obviously, at the community level, they'll be dropped off by a parent. Parents often like to stay and watch their kids training. Volunteers obviously are often around, setting up equipment or doing other roles. Unfortunately, the numbers are what the numbers are. We think that should stick to that. So if you're in a sport where you need specific equipment set up, you try and get the athletes to actually help set it up. And if you need a volunteer to be there as well as the coach, then that probably reduces the number of athletes you can have there. But so effectively, you try and get by at level B with the minimum number of staff that you can possibly get by with. And if parents and others are on the sideline of either training or watching a match when we get back to level C, then it's really important that those spectators remain separate from the athletes, and that the spectators themselves maintain a social distance of 1.5 metres, because it could be the crowd or those watching on that actually pose the risk to athletes in the community. So everybody needs to do their bit. Whether it's coaches, volunteers, spectators.
You mentioned youth sports. Have you addressed that in your framework?
No, we haven't. And this is an area that is controversial and it's contested. Their children seem to be less affected than adults certainly they are less affected in terms of the severity of the disease. We certainly aren't seeing a lot of children suffering serious disease. There are some children that have been adversely affected, but as a general rule, children seem to manage this condition, handle this condition much better than adults. But the debate is around whether children can be asymptomatic transmitters of the disease, and I've heard, vociferous debates about this, where there are very highly credentialed individuals at either end of the debate, and there's a lot of passion around that debate. So, for me, I've read as much of the evidence as I can, and to me it still seems a little bit unclear as to whether we can conclude that children's sport poses less of a risk of adult sport. I think it probably does, but there is no such thing as purely adult sport. I mean, even all children's sport requires adults, whether they're volunteers or parents dropping them off or coaches. They require supervision, so there will always inherently be adults involved. And so it's not purely child sport. There are adults involved, and our personal feeling on reviewing the evidence as we brought this out was that we couldn't clearly make a differentiator between children and adults, and then it becomes, where do you draw the line? You're talking about at age 18, is it at age 15? And the evidence just is not conclusive enough, we felt, at this stage to differentiate in our framework between children and adults. And there's also the compromise. Any time you subdivide groups, you lose some clarity of message, and you have to weigh that up. Where we feel there is strong evidence for something, then it's worth including that in the message. If the evidence is contested or inconclusive or debated, then you have to be very careful about going down one path or the other, because you could spark a backlash from those who don't agree, and your key messages can then get lost in the debate. And for those reasons, we felt that clarity of message around how to safely reboot was more important than trying to differentiate between children and adults, where we didn't feel there was sufficient, or the evidence was not robust enough for us to confidently make some recommendations in that regard.
Okay, let's shift gears a little bit and talk about individual sports. How are they affected?
Probably they're the most fortunate ones. So I was speaking to someone who is a high-performance javelin thrower in the past couple of days, and he was saying that he and his coach were able to actually almost train fully at level A, because it only required two people. Even when in normal state of affairs, there's usually only the two of them training together, just him and his coach. They go to the training facility. They are outdoors. They're not indoors. He can do his strength training at home because he has his own gymnasium. But in terms of actually throwing the javelin, he's able to just work with his coach in a fairly normal manner, maintaining social distance between him and his coach. Similarly, for say a sport like tennis, we have two people who are widely separated. Tennis, under our framework, is effectively back to full competition by the time they get back to level B, because they're maintaining social distance. There's only 4 people on the court and an umpire who's widely separated, so you can easily have a singles or doubles tennis match at full competitive level at level B, satisfying all those level B requirements. So yeah, there's certainly a difference, and probably the sports that will return sooner are those that can be done in ones or twos, or in numbers that involve less than 10 people.
And I just want to highlight this point that you brought up several times, that it just comes down to the individual. So it is the things that we do ourselves, like washing our hands, respiratory hygiene, maintaining social distance. Also, not attending work or sports facilities when we have symptoms of COVID-19. So, for example, cough, sore throat, fever, shortness of breath. So if we have any of these symptoms and we are not attending those training facilities or work, things like that is the way forward to contain COVID-19. And I'm keen to hear about your thoughts around this.
And that's why education is so important, because athletes need to understand they're young, they're exuberant, they love the company of their friends, and they love to get in and mix up, and they're used to having a lot of physical and social contact with their peers, and we do need to educate them and give them a higher level of health literacy around COVID-19, so they understand the decisions about why we need to behave differently. But you're absolutely right, it's the simple things, those social behaviours around hand washing, etc., that are going to determine whether we are successful. And I certainly don't take it for granted, but I at least feel comfortable that we have a plan, and that the plan is being adopted fairly universally in Australia, with some differences between sports and some differences between regions, but generally the principles are the same. And I think the plan has more chance of succeeding if there's widespread acceptance.
So one last question before we wrap up. And David, if you have a crystal ball, you might want to look into that. When do you think we will see mass sports events with spectators, like football matches, marathons?
Yeah, look, it'll vary around the world. I think I'm really cognizant that we're talking about sport here, and there are many people around the world who have lost their lives, and many communities that have been devastated by huge loss of life in places like Italy and Spain, and other places in Europe, and of course now in the United States. So we are just talking about sport. And it's so much variability between countries. In Australia and in New Zealand, we're very fortunate in having low transmission rates. If everything goes well here in Australia, a lot of sports are moving to level B this week, and we're talking in mid-May here, so we're moving to level B. If we don't have any outbreaks in sport, and if everything goes well, there's a possibility that some sports will move back to level C maybe in about 4 weeks from now. Again, it comes down to government decisions at the state and territory level, but there is a possibility of that. In terms of some of those sports like marathon races and large road races that involve, big numbers of participants, they are really mass gatherings. And just as mass gatherings were the first thing to go as we close down, I think they'll be the last thing to come back. It's so hard to predict the future, because it's incredible to think that even in mid-January here in Australia, whilst at the Australian Open, we were worried about bushfire smoke, but we weren't even talking about this virus. And here we are, 4 months after the Australian Open, and so much has happened in that time in so many different countries that I don't think anybody can confidently say what we will look like in 4 months from now. But if everything went really well, potentially some of those mass events could maybe happen in the latter part of this year. Again, it will all come down to what is happening in the rest of society. But it wouldn't surprise me if we didn't have any mass gatherings in 2020.
Okay, let's wrap it up there. Thank you so much for your time, David. If you want to know more about the AIS framework, you can look at www.ais.gov.au, and it's the first tile on the AIS website. Also, the framework is published on JSAMS in their COVID-19 special issue, so you can access it as an open access publication. I have also shared the links to the AIS website as well as the JSAM special issue here, so you can easily access those resources. If you have any questions for David, feel free to post them here. Once again, thank you so much for joining us today, David, and a huge thank you to our listeners for connecting with us.
Thanks, Nim. I really appreciate it. And just to add one more thing, just to make it clear that JSAM special edition, all of the documents associated with the framework are open access, so they're free to download. So again, we would like to think that if they're useful for anybody, we're very happy for those to be used and adapted to your own environment. So thank you very much, and I wish all my colleagues and friends around the world all the best of luck as they all go on their own journey in rebooting sport in the COVID-19 environment. Thank you.